So the patient's been waiting in the waiting room for a while. They had some analgesia, and it's time to bring the patient into the department. So here's the routine for bringing a patient in and the next steps. So the first thing you want to do is you want to select your patient. You want to go ahead and sign up for that patient. The sign up piece does not mean that this is the only person responsible for the patient. Other people in the unit can still order and do things for the patient. If you're the person on the patient's list and you're tied up somewhere else in recess one, for example, and you don't want to be held responsible for this patient, you can undo your sign up as well. So just to kind of a piece. So the patient's already been registered by admitting, so we're good with that. So now we need to put the patient in a room. So to put them in a room, you're just going to basically click here. You're going to go and find the room that's in. So even if the room is indicated as dirty, that's not a problem. You can still select a room as long as you know that it's clean. You can go ahead and select the room, and you can actually, if there's other dirty rooms, you can actually clean them from this point here. So I'm going to put that patient in that room, and I'm going to go ahead. So side note, if the patient is a second patient in the room, you can put them in the treatment flex, which I explained it a little bit better in the longer video. So now we've got our patient in an exam room. Sorry. Got our patient in an exam room. Save. Close. Our patient should now no longer stay in this waiting room. So if we refresh here, they're going to fall off the waiting room tracker. They are now going to be in the tracker for exam treatment flex. That's where you're going to find your patient, or you're going to automatically find them on your My List because you signed up for your patient. Again, you've got your triage notes to review and all those things if you want to. So now we need to reassess our patient and we need to do those pieces. So here's what we're going to do. We're going to go to our documentation tab, or document tab, and we're going to go to the work list. Sorry, I do need to select the patient before I do that. And I'm going to go ahead and do my documentation. So now, a couple things. So I'm probably going to want to do a repeat set of vitals on the patient. If the patient was still in triage and I was just doing a reassessment of the patient, I can just document strictly on this piece. But because I'm bringing them in, I'm going to do a set of vital signs. And every primary complaint or CEDAS complaint triggers an assessment that is related to that complaint. For lower level patients who are not acute, that is probably going to be sufficient for their assessments. For patients who are any higher than the CTAS-3, you probably need to add some secondary assessment pieces there as well. So our patient in this case doesn't need that extra stuff. If you were going to add an IV line, then you would put an IV line here. If you're going to put them on a cardiac monitor, you're going to do that here as well. So those are the pieces when you bring the patient in. We've already done our infection control and all those pieces there. You can see them documented. So now we're going to click on the document button, and we're going to do an initial assessment, and you review your triage of information. No change with this particular patient. So this laceration wound thing, so we know that it's accidental. We determined that her tetanus is up to date. We're going to go here and we're going to select from the list. So her first left toe is where the injury exists. It is a laceration. It is unapproximated. So there's no wound levels here for this particular incident. Exudate, so she's got a moderate amount of bleeding happening. And then so exudate odor, it's a fresh wound, so it wouldn't be a thing. Length of the wound, we did determine that it was 2 centimeters when we assessed it earlier, so we're happy with that. The depth is kind of tricky. You know, it might be 0.3 centimeters or whatever if you really want to get technical. For a small laceration like this, I don't know that it would be that important, but for a larger wound, for sure. Wound bed, again, more than likely a healthy wound bed because it's a fresh wound. You're not going to have any serious edema to surrounding tissue, or there may be some swelling, in which case then you can indicate that you do have some edema to surrounding tissues. The peri wound, so again, bruising and all those things probably would not happen. Skin's probably intact in this point. And then no granulation, no slough, no eschar because it's a fresh wound again. So dressing, so we did put a dressing in the triage, so we put it there. If we were going to expose the wound, then we might do dressing change. We might put that we cleansed it with saline and that we put some gauze on the wound. We might have irrigated the wound with a bottle of saline as well. So there's a couple of options there. And then we're going to basically, I think that pretty much covers everything that we're going to need. Maybe we secured it with a gauze roll, whatever. And then we're going to do our repeat set of vitals here, right? Because we do want to have vitals. Again, you're going to have to add a location for your vitals because the ones from EC are not going to carry over, just so you know. And then, so I got those pieces there. Saturation's 95. We're there. You do need to put a blood pressure location. And she's got a perfectly normal blood pressure. So we're happy with that. Automatic cuff, it is at rest. She is still having pain despite the fact that we gave her something for pain. So we're going to do a pain assessment here. So I'm just actually, for the initial pain assessment, I would actually avoid doing it here. And I'll show you why in a second. So if you find your pain assessment, pain acute in here, there's a little bit more detail to the pain here. So I'm going to go ahead and add that pain to the left toe, first digit. It might be the whole foot in this particular case. So I'm going to say that she still has 7 out of 10. It's aching. Is it radiating? Sure. At rest and with movement, absolutely. She dropped something really heavy on her foot. She probably had some facial cringing. So you don't have these details in the vitals version of the pain. So what makes it better? Well, maybe some cold. Is the pain constant? Probably. What makes it worse? Activity for sure. And then, weight bearing would probably make that painful as well. And then interventions currently. So we did give some pain medicine in the triage room. And then, so we're going to go ahead. Oh, I'm missing some fields here. Sorry, numeric. And I'm going to go ahead and save that. So now I have documented my assessments on this patient. And again, for a sicker patient, I might want to go into the secondary assessment and then do my documentation by systems. You don't have to document on all systems, but you may want to specify one system, like for a respiratory patient, you may want to go in there and do a little bit more thorough. If there's some cardiovascular issues, you may want to do that. For a chest pain patient, I would probably want to do all of those things. So just one piece to keep in mind. And now that I've done that documentation on the patient, the other thing that I neglected to show you here. So while I'm doing that assessment, I can put the patient status as nurse assessing while I'm in here. And that will show that somebody is with the patient right now. If anybody else is looking to do something with the patient, X-ray might be looking for the patient for an X-ray or whatever it might be. Once I have completed looking after the patient, I can go ahead and change that status to be seen. And that will now flow to the to be seen tracker on the physician side, which is where they will start seeing patients, the equivalent of putting that clipboard in front of them on the desk. And that is the nursing piece for bringing in a patient.